All right, good morning, everyone. This is Rebecca Allegan, the Senior Policy Analyst at the Office of Licensure and Certification at the Virginia Department of Health. I'd like to welcome everyone to the Regulatory Advisory Panel that we are convening today for 12VAC5-371 and 12VAC5-391. This meeting is being conducted in a completely virtual environment and is being recorded. There are several things I would like to review before we get started. First, if you need technical assistance, I ask that you do not email me asking for assistance. Instead, please use the chat function inside of WebEx. I only have one monitor that I'm working with, and it's difficult for me to be flipping back and forth between the WebEx window and my email account if you're trying to contact me that way for assistance. So if you need assistance, please use the chat function inside of WebEx, and I will do my best to assist you. Additionally, since this is a virtual environment, we do ask that you please mute your lines when you are not speaking, as this reduces the amount of background noise on the call and the potential for audio feedback or reverb. We also ask that you please identify yourself each time you begin to speak so that we know who is speaking and that we can accurately record the minutes of the meeting. For those attendees who are not members of the Regulatory Advisory Panel, you will not be able to unmute yourselves. When we get to the public comment period, for those of you who have signed up to speak, you will be unmuted by the host if you have signed up. With that being said, I'm going to go through the roll call right now. One moment. Okay. David Abraham or his designee, Rebecca Morales, are you on the line?
Yes, I am. Thank you. Good morning.
Thank you. Good morning. Melissa Andrews?
This is Dana Parsons. Melissa is on vacation this week.
Oh, okay. Thank you. John Burns or his designee, Will Blackwell? Which, one moment, I believe Mr. Blackwell called in using our attendee line. So if you all will give me one moment, I will try to get him unmuted so that he can join the call. Mr. Blackwell, are you there?
Yes, I am. I'm here.
All right, thank you. Liddy Bush sent back that she was unable to attend this meeting today. Will Coleman or his designee, Colleen Lobb, are either of you on the line?
We're here. Thank you.
All right, thank you. Thank you. Ronald Cottrell, are you on the line?
I am. Thanks for having me.
All right, thank you. And if I mispronounce anyone's names, please let me know and I will correct that. David DiBiase, are you on the line? Joanne Dawson, I see her on the line, but she is actually as an attendee. So one moment, I need to bump her up to panelist so she can unmute herself. Ms. Dawson, are you there?
Yes, I am. Thank you.
Thank you. Morris Funk, are you there?
This is Dana Parsons again. Mo will not be joining for the meeting today.
Okay. Carter Harrison?
I'm here.
Tracy Jennings?
Yes, I'm here.
Richard Kennedy? Tom, oh, one second. Someone just messaged me. Okay. To the person who just messaged me, yes, I will take care of that as soon as I wrap up the roll call. Tom, I apologize for mispronouncing this. Kusumpis?
Kasumpis, but this is Matt Kestenbaum attending on his behalf.
All right, thank you. Thank you for correcting my pronunciation.
Sure.
All right, Jenny Latimer?
I'm here. Thank you.
Vivian McDaniel?
I'm here. This is Vivian McDaniel, and I am here representing Virginia Nurses Association, not Aspen School of Nursing.
All right. I will make sure that is reflected on the next presentation that we do, and also in the minutes for this meeting. Catherine Morrison? Okay. I do see that Joni Latimer's on the line. Are you there?
I am here. I don't know why it's muted. Can you hear me?
All right. Yes, I can. Thank you. And I know Dana Parsons is on the line. Hello, Dana.
Hello.
April Payne? I do see a representative from VHCA in the attendee list. One second. Alicia Cundiff, are you here representing VHCA today, or are you just observing this one?
Alicia represents Leading Age.
Well,
yeah,
sorry?
I represent Leading Age.
Okay. One second, I'll bump you up then. Greg Storer? Are you on the line? Marcy Tetterton? Carla Thompson? Corey Tillman-Wolf?
I'm here.
All right, thank you. Veronica Williams?
Here, thank you.
Thank you. Mindy Wittenbach-Lindsay? Okay, not seeing anyone. Okay, and April Payne just messaged me. She is on the line. Since you're a call-in, April, I'm not going to be able to bump you up to panelist, but what I'm going to do is I'm going to unmute your line. And so if you will handle the muting and unmuting of your line through your own cell phone, that would be great.
Absolutely. Can you hear me now?
Yes, I can.
Oh, yeah, I'll keep my line muted.
All right, thank you.
Good morning, Rebecca. This is Carla Thompson. I don't know if you heard me.
All right, yes, thank you, Ms. Thompson. Okay, and did Mindy Wittenbach-Lindsay join the call? Okay, not seeing anything. Not hearing anything, I should say. I am present. Is Kim Beasley on the line?
I'm here, Rebecca. Can you hear me?
Yes, ma'am. Kristen Collins?
I'm here.
Joe Hilbert? Sarah File-Lineberger?
Yes, good morning.
Ruth Morrison? Sarah Noble?
I'm here. Good morning.
Brendan Rivenbark?
Yes, I'm here. Good morning.
Good morning. All right. Thank you, everyone. So moving on, today's agenda, which was sent to you all, but just as a refresher for you all who maybe looked at it once, don't recall exactly what the layout is of the land. We are going to begin with a public comment period, followed by a review of what the charge of this regulatory advisory panel is. Then an overview of the visitation guidance that has been issued by CMS to date, both for the nursing homes and the hospice facilities. Then Ms. Lineberger is going to take over and discuss the COVID-19 related conditions in facilities and communities for that would indicate either in-person or virtual visitation needs to take place. And then we'll move on to a general discussion amongst all of the panel members about and recommendations regarding what conditions bear on the decision for either in-person or virtual visitation, and then we will wrap up and discuss the next steps and setting the next meeting date for the regulatory advisory panel. So with all of that being said, for the public comment period, we did not receive any written comments in advance of this this particular work group. But we do have several folks who have signed up to offer oral comments today. And if you will give me just 1 second, I will get all of these lines set up. Okay. When registering for the meeting, members of the public were given the opportunity to sign up to speak on a topic if they wish. Pursuant to the Board of Health's existing public participation policy, each speaker is going to be given a maximum of 2 minutes in which to speak. There will be a countdown timer on the screen, and a bell will ring when that time is elapsed. If the bell rings when the person is speaking, we do allow the speaker to finish up that sentence, and then the speaker is going to be muted, and the name of the next speaker will be called. When it is your turn, you will be unmuted by the hosts. In addition, all the speakers are reminded that this is your opportunity to address the regulatory advisory panel on any topic of your choosing. However, it's not a question and answer period, and there's not going to be dialogue back and forth between the speakers and the members of the regulatory advisory panel. With all of that being said, the first person who signed up to speak today is someone by the name of Rachel Mendez. And I do not see Ms. Mendez in the attendees list right now because the only call-in user we have is April, and everyone else has been identified. So Ms. Mendez is not with us. The next person who is signed up to speak is, I think actually that was the only person who was signed up to speak. Everyone else who signed up to attend did not indicate that they were interested in speaking. And I will note that for everyone in the room who may not be able to see the attendees list, that we do have Carol Jamerson with VDH who's attending the meeting. We have Judy Hackler who is with VALA, and also Katie Finley, who is with the Secretary's office. Okay, but since they didn't sign up to offer public comment, we will be moving on. Okay, so the charge of the Regulatory Advisory Panel. Some of you who are on this call may have served on a Regulatory Advisory Panel in the past, but for those of you who have not, this is going to be both an overview of what they are generally and what this specific Regulatory Advisory Panel has been convened for. So a Regulatory Advisory Panel is appointed by an agency, in this case, the Department of Health, that is planning to implement a regulatory action. And the purpose of it is to provide specialization, expertise, technical assistance to the agency as it is working on the regulatory action that is to be promulgated. And it's utilized whenever the agency determines that sort of expertise is necessary to address specific regulatory issues or actions before it. And that we do have, VDH, as does every state agency, has public participation guideline regulations, and there's a specific regulation that addresses the appointment of the Regulatory Advisory Panel. So the reason, that's what they're for, that's what they're utilized. The reason why we specifically have called this Regulatory Advisory Panel is during the General Assembly special session that began in August, is going on right now and is beginning to wrap up, there were two separate bills that came through, HB 5041, which the patron is Delegate Head, and SB 5042, and the patron being Senator Kiggins. Though they didn't start out this way, these two bills are now identical, and they have the same mandate in them, that the State Board of Health promulgate emergency regulations to address visitation in nursing homes, certified nursing facilities, and hospice facilities. The bill text lists several sets of requirements that are to be included in those regulations, and this RAP will be providing assistance, expertise, and input to the State Board of Health about those requirements that are listed in the bill text itself. I mentioned that they are bills and not chapters or actual changes to the code yet, because while they have, both bills have passed both houses of the General Assembly unanimously and are going to be transmitted to the Governor's Office has not taken action on them yet, but VDH is anticipating that this is likely going to be the case, that there's going to be action taken on this. So knowing that that's coming down the pike and also knowing the intense interest in the regulated community, both the nursing homes and the hospice facilities, concerning visitation, we thought it best to get this regulatory advisory panel stood up and to begin the work on the visitation regulations that the Board of Health is going to be asked to work on. So the actual bill text itself, it's a relatively short bill, but the requirements are a big block paragraph, so I have broken them up, and there is a set for the nursing homes and certified nursing facilities, and there's a set for the hospice facilities. The requirements for both are the same. So as you can see on the screen, the one that is specific to the nursing homes, it amends Virginia Code Section 32.1, 127, subsection B. It adds a new subsection 28 in there, and says that during this COVID-19 public health emergency that Board of Health's got to require nursing homes and certified nursing facilities to have visitation protocols consistent with CDC guidance and as directed by CMS and the State Board of Health. That visitation protocol has to include, as I mentioned, a number of things. The one that we are going to focus on today is the first in that list. In our subsequent meetings of this regulatory advisory panel, we'll work our way through the remainder of these requirements, but for today, we're focusing on that first one, which is conditions, including conditions related to the presence of COVID-19 in the nursing home, certified nursing facility, and community, under which in-person visits will be allowed and under which in-person visits will not be allowed and visits will be required to be virtual. So that's the one that we are concentrating on today. You can see that there are others as well, so requirements for visitors to comply with to protect health and safety, the types of technology that's going to enable those virtual visitations, and the steps that the facilities would need to take in the event of a failure of the technology, service interruption, or other emergency. There are also some additional requirements on the facility. Specifically that the visitation protocol has to have a statement about the frequency of the visits, authorizing the patient or the resident or the resident's personal representative to limit or waive visitation, and a requirement that the facility publish on its website or in some other way communicate to the residents and their authorized rep what the plan is for requiring or for providing the visits that are required. So that is what is required of the nursing homes and certified nursing facilities. As I said, this is nearly the same for the hospice facilities. The only difference is the words leading in. So it amends 32.1-162.5. It adds a new subsection C. Again, the hospice facilities, they have to have a visitation protocol consistent with CDC, CMS, and the State Board of Health. You'll see it's the exact same for things that need to be addressed in the protocol. Again, we're concentrating on number one today. And the protocol, just like the ones for the nursing homes and hospice, or nursing homes and certified nursing facilities, has specific things that must be included in regarding the statement about the frequency and how they're going to communicate that to folks, et cetera. So that is what HB 5041, SB 5042, those are the mandates that are being placed on the State Board of Health, which is why we have called you all here today. So with that being said, I'm going to do a quick overview of what the guidance to date has been from CMS, since whatever visitation recommendations that this group comes up with, as you saw in the language of the bills, has to be consistent with what CMS has said. So for the certified nursing facilities, and for those who may be asking, well, what's the difference between the certified nursing facilities and the nursing homes? Under Virginia state law, a nursing home is a licensed facility to provide nursing care. A certified nursing facility is a facility that is certified to participate in Medicare and Medicaid. You don't necessarily have to be licensed in order to be certified. There are some facilities that do not hold a license but are certified. So that is the distinction in Virginia state law, in case you're wondering why those two terms are being used in the bill. So the CMS guidance is obviously applicable to the certified nursing facilities, the facilities that are out there that are licensed only, that do not participate, which there are a few. This guidance that CMS has put out is certainly instructive, but is not something that they are required to comply with because they don't participate. So just as an FYI to everyone. So the CMS guidance to date, we had a memo come out in March 2020 that shut down visitation pretty much across the board except for certain compassionate care situations. In May, there was another memo that talked about reopening recommendations that were providing additional guidance to the nursing homes as to how to approach that phased reopening. They also came out in June with an FAQ that expanded on the previously issued guidance about outdoor visits, compassionate care, communal activities. The most recent one that has come out is quite a bit more detailed, and that's QSO 2039NH, which just came out last month, and it supersedes everything that has come out to date. So the March, May, and June guidance, we can put that away. We are only playing in the realm of the March memo, which has a lot of guidance and recommendations regarding the visitation in certified nursing facilities. On the hospice side of things, there was guidance issued in March, and there has been nothing more specific since for the hospice facilities. So it does address that the hospices should screen visitors and patients in directly provided short-term inpatient care or if they're in an inpatient unit of another facility. There is a question and answer within that QSO 2016 hospice memo about whether hospices can restrict visitation, which you can see the answer here on the screen. But to date, that is all that CMS has really given the hospice facilities. So while it's good that we have quite a bit more detail on the nursing home side, as you saw from the bill, these are regulations for both nursing home and hospice facilities. So as we work through these discussions, we need to make sure that whatever recommendations we are coming up with also address the hospice facility portion of the equation as well. So speaking of QSO 2039NH, the most recent one from September, for those online who maybe haven't had a chance to read through it, or for our hospice folks who this wouldn't have applied to them, so they may not have taken the time to read it since it wouldn't have applied to their facilities. So it addresses the visitation being able to be conducted through different means based on a facility structure and the resident needs. It addresses different types of visitation within that memo, so indoor, in-person, outdoor, in-person, virtual, and compassionate care. It lays out that representatives of the state long-term care ombudsman's office and of the protection and advocacy system, they have to have immediate access to any resident. Though the access, it's preferred to be in person, but if it cannot be, it still has to be provided through at least virtual means. That healthcare workers who are providing direct care must be permitted into the facility as long as they're not excluded because they've been exposed to COVID-19 or they've, after being screened, have shown signs of symptoms of having contracted COVID-19, and that EMS personnel do not need to be screened. This memo also contains what CMS is calling core principles of COVID-19 infection prevention. I will not read all of them to you, but it is a general overview of the guidance going in any sort of situation dealing with COVID-19 in the certified nursing facilities. They also, this memo goes into detail about what specific COVID epidemiological conditions inform visitation, whether it should take place or not. And as to that point, since I'm with Office of Licensure and Certification and not the Office of Epidemiology, I'm actually going to hand it off to Sarah Feil-Leinberger, who is with our Office of Epidemiology, to speak to those specific conditions that CMS has identified. Sarah, are you still on the line?
I am. Can you hear me?
Yes, I can.
Sure. So the September CMS memo that you mentioned for nursing homes essentially lays out that outdoor visitation, as we know, poses a lower risk of transmission And for indoor visitation, they lay out guidance on when that should happen, when it would be safe to do so. And that includes that the facility isn't currently experiencing an outbreak or conducting testing for a suspect outbreak. For COVID-19, we define an outbreak as 2 or more cases in a facility that are epi-linked, and additionally, that there's been no new onset of COVID-19 cases in the last 14 days in the facility, and that's consistent with guidance that we've issued from VDH throughout the pandemic. We've referred to nursing home onset cases, and so there shouldn't have been new onset of cases in the facility in the last 14 days. That would not include if somebody has been transferred from a hospital or other facility who's known to be positive into the facility. That wouldn't necessarily preclude a facility from, from allowing visitation, but there shouldn't be new onset in the facility in the last 14 days. And CMS further directs facilities to use the COVID-19 county positivity rate to determine when indoor visitation should be conducted, and essentially says that if a facility is in a county with 10% or less percent positivity, that indoor visitation should be allowed. The CMS data are available, and they're updating it about every 2 weeks for counties. And VDH has actually also this week released data for nursing homes that can be used as well. And it's percent positivity data by locality, so by county or city in Virginia. And in discussions with OLC, we've determined that nursing facilities in Virginia can use either the CMS data or the VDH data that have been posted to determine percent positivity in their locality, and essentially just that facilities would need to document the data source they're using and use the same data source consistently. But essentially, any facilities in the low category for percent positivity or medium category, so anything less than 10%, CMS is allowing indoor visitation, or essentially saying indoor visitation should be occurring or should be allowed. The percent positivity data is all based on PCR data, so that's molecular data. At this time, none of that data includes antigen data. There are discussions for that to change, both at the VDH state level and at the national level, but as far as we know, that's all PCR data. So those are essentially any lab reports, any labs being conducted, molecular lab testing being conducted in the state, all goes into our Virginia electronic disease surveillance system. And that data, those data are shared with both CDC and CMS on a regular basis. And so that's where the percent positivity data are coming from. And I'm happy to go into that in more detail. So essentially, facility isn't currently experiencing an outbreak to allow indoor visitation. They haven't had new onset of COVID-19 cases in the last 14 days. They're in a locality with 10% or less percent positivity. And importantly, and what's outlined in the September CMS memo, is that they're also able to follow core principles of COVID-19 infection prevention guidance from both CMS and CDC, including having staff available to monitor adherence to guidance, and that includes things that we've been talking about throughout the pandemic, like screening visitors, ensuring visitors and residents are wearing face coverings, having enough PPE, personal protective equipment for all parties involved, having enough environmental cleaning supplies, et cetera. So really just trying to prevent any transmission when allowing indoor visitation. And for hospice facilities specifically, like Rebecca mentioned, there's been less CMS guidance but CMS does refer to compassionate care situations, and so that is guidance that we could use for hospice facilities. Rebecca, is there anything else specific that you want me to mention right now?
Nothing specific comes to mind, but thank you for going over that with us.
Sure.
All right. With all of that being said, now that we've, hopefully we're all on the same page, we're all coming from the same starting point in terms of what the General Assembly is expecting, that we'll be addressing what CMS has already put out there, both for the nursing homes and certified nursing facilities, as well as for hospice. I'd like to open up the floor to discuss the conditions that would indicate yes for in-person visitation and no, it needs to be virtual visitation. As a reminder, if you're not speaking, please mute yourself so we don't get the audio reverb. When you do speak, please identify yourself. While I've met many of you, I've certainly not met all of you, and I'm not 100% familiar with the sound of everyone's voice, so that will be extremely helpful to me, and I'm sure others on the call. I would like, as part of our discussions, that we think about some of these questions that I have displayed up on the screen, since there has been a little bit of a disparity just through CMS in terms of what guidance is being given to the nursing homes and certified nursing facilities versus hospice. One thing I'd like us to consider is, should the state's requirements, the regulations we're talking about putting out there, should those requirements be the same for both types of facilities, or should we be distinguishing that there's going to be certain separate requirements for hospice and that aren't placed on nursing homes or vice versa? What non-COVID-19 related conditions could impact whether to permit in-person visitation, and what conditions in the facility and or community should inform the decision to permit in-person outdoor versus in-person indoor visitation, because CMS does distinguish between the two of them. So again, and the conditions don't necessarily have to be COVID-19 specific. We do have to address COVID-19, but they don't have to be specific, as you may recall from the language of the bill text. So with those kind of questions sitting in your mind, like I said, I open up the floor to whomever would like to speak. Again, when you unmute your line, please identify yourself. So. And if no one volunteers, I'll start calling on people. So hopefully that encourages folks to maybe jump in before I resort to that.
Hey, Rebecca, this is Sarah Lineberger again. Can I just comment on the second question?
Sure.
So as part of routine at the investigations, we do sometimes recommend that a facility limit visitation if the facility is experiencing an outbreak for another infectious disease. That might be something like influenza or norovirus. And so I don't know if it would be captured in these regulations, but there are certainly situations in our routine work where we would limit visitation just for a period of time to protect both residents and visitors from any sort of ongoing transmission in the facility.
All right, thank you for that. With those other infectious, because certainly we are heading into flu season, and as a reminder, please go get your flu shots. With those other infectious diseases that could be causing an outbreak, or just maybe not a full-fledged outbreak, but you're seeing it in the community, or not in the community, in the maybe in the facility itself. What metrics should, if that were something that would be one of the conditions they need to consider, where would a facility need to look in terms, like what numbers, what metrics would they be looking at? I know for COVID it's the county positivity rate. What should they be looking at for things like influenza?
Sure. For influenza, I mean, there are more preventative measures that we can have in place before an outbreak happens, such as vaccination, and certainly, residents are offered influenza vaccination, and we strongly encourage influenza vaccination for all staff in these facilities as well. So it typically has less to do with what's happening in the community and more with what's happening in the facility to just make sure the facility has time to sort of get transmission under control. So sometimes limiting visitation might even just be for a couple days so that the facility can sort of get any sort of outbreak under control and have time to put additional measures into place to stop transmission. So it's sort of made on a case-by-case basis, generally with the local health department. And again, not something we would typically put in regulation, but more like guidance. But since you asked the question, I just wanted to bring it up. There are other things that we would typically do as well. Sometimes during an outbreak, a wide range of infectious diseases, including COVID-19, might ask the facility to stop accepting new admissions. Again, that's usually just for a period of time until the outbreak and ongoing transmission can be controlled.
This is Veronica, and I'm looking at the questions. Can everyone hear me clearly?
Yes, I can.
Sarah, okay, great. As I look at the questions that you're asking us to discuss, as an elder law attorney, there are, I guess, a couple of things that I would like for everyone to consider. In the midst of COVID, I've had occasion to visit several facilities in the capacity as either counsel for a resident or in capacity as a court-appointed counsel in a guardianship proceeding or as court-appointed guardian ad litem. And I'll tell you something that was brought to my attention this week. A family, I was appointed as guardian ad litem, and a family reached out to me because they thought that the scope of my role was, I guess, a little bit larger than it is. But they were allowed to do, for the first time since COVID started, they were allowed to do outdoor in-person visitation. And they had a really devastating experience. Their wife and mother, they found her in a condition that they couldn't ascertain from all of the video meetings that they had during COVID. They found that her hair was matted. She had places where her hair had bald spots. The condition of her skin was really poor. And they say they literally left like silent, everybody just in the car silent and crying, and the patient's husband physically got sick because of the condition they found the patient in. So when we discuss the purpose for the visitation restrictions, I know that there's a public safety concern. Is there a way to address the public safety by limiting visitation to only the patient you're coming to see, and putting enhanced sanitization protocols in place, et cetera, and even limiting the duration, but enough so that number one, that patient can get some contact so that they're not isolated from people upon whom they rely emotionally, and also so that those loved ones can have that in-person view, that where they can see things that are not going to be visible during the virtual. And that's just something for us to perhaps discuss as a multidisciplinary panel.
Hi, this is Rebecca Morales with Beth Shalom. That's a really terrible situation. I hate to hear that happen with anybody. What we've been doing, of course, are drive-up visits, so people can see their loved ones outdoors, but they are very restricted, and families can't get out and have any type of contact. There's a barrier, and there is strict infection control followed with that. But as just some education on how to provide a barrier and limit contact, even with the outdoor visitation, there has to be that social distance with the families. So there's not going to be that close contact even with the outdoor visitation. So I just wanted to make sure that that was very clear. And it would be, of course, the same with the indoor visitation. All of the socially distant appropriate restrictions have to apply because we don't want that outbreak to occur in our facilities. And I just wanted to put that, to preface that on one of the comments that you did make in regards to having that encounter. And then we can go forward with any type of conversation.
Rebecca, this is Tony Latimer.
Yes.
Go ahead. I didn't mean to speak over someone else I heard, but no, I was just going to kind of piggyback on both of those comments. I think we've certainly, as a program, seen a lot of these concerning scenarios where there's just, been some major decline with residents for lots of reasons related to the crisis at hand, but certainly the social isolation in many of those cases has played a huge role in that. And so I think all of us were relieved and appreciative of CMS's clarification, its new guidance to enable much more opportunity for the in-person visits. And I guess one thing I would say is I just would underscore or ask for maybe you all, the experts at VDH and Rebecca and Sarah and so forth, what seems clear in this is that the guidance we're now operating from is really endorsing the in-person visitation, but for certain circumstances that would disallow that. So it's really leaning toward encouraging this for this very reason, because, many of our conversations at the national level with CMS have brought these issues of concern of ill effects of protracted isolation on residents to the fore. But the other thing, just in relationship to that, in light of the fact that we have had such scenarios, and as one of our speakers has said, hopefully those are the exceptions here, but they're very concerning and they're very serious repercussions. One of the things that's not addressed because they're not federal level programs, they are state level programs, so it's particularly important for us in this group to consider at some point addressing access by adult protective services as well as the public guardians who have a responsibility to monitor their individuals. They're essentially, in many cases, the family, quote unquote, for that individual resident. And I just want to make sure that I didn't know that this was necessarily the point at which to interject that, but it's an important issue, I think, for all of us to give serious thought to and make sure that our state guidance does address access for those individuals, particularly in light of some of the things we have unfortunately seen over time. So thank you.
Thank you. And I will say on the subject of APS, as well as also Child Protective Services, because while it doesn't happen, I mean, in terms of the population, minors don't make up a large percentage of it, but there are minors who are in nursing homes or who are in hospice facilities. So access by CPS would also be something to be addressed. But
right.
looking at the condition, not the conditions, excuse me, looking at the list of enumerated items that the General Assembly wants the State Board of Health to address in regulation, I think that sort of question of access while still making sure health and safety is protected would fit probably better under the two little I that was listed there. So first one was conditions. The second one was what do the in-person visitors have to do to protect health, patient health and safety when they're coming in. I think as part of that question, who is the visitor, who gets permitted in, both just to visit family and friends, but also in order to do their jobs. I think that conversation would probably fit better under that particular topic, which I plan on discussing at the next one. I plan on just kind of going down the list that the General Assembly has laid out first. But yes, that is certainly something that that is on my radar. I know we've had conversations internally at OLC specific to the APS issue. So yes, that is on the radar. And like I said, I think we also need to make sure CPS is something we consider because though they don't make up a significant portion of the population, minors do occasionally show up in those in these facilities. So they also need to be protected as well and have access by CPS. So thank you for pointing that out, Ms. Latimer.
Rebecca, it's Carter Harrison. Can you hear me?
Yes, I can.
I have a question about the CMS guidance. Is Department of Health considering the guidance to be a floor or a ceiling? In other words, they do reference some specific things that are necessary for in-person visitation on their guidance document. And I want to make sure that is that being considered the minimum that has to be done, or is that the maximum? And I ask that question because they also talk about, violations if you don't follow the CMS guidance. So, can you answer that question for me?
Okay, so depending on what specific part of the memo you're talking about, when it comes to the interplay between here's what the state requires and here's what the feds require, they cannot be incompatible. Because if they are incompatible, facilities are going to do what the feds say, not what the state says, because they don't want to jeopardize their funding, which makes complete sense. So the state certainly can be more specific and more detailed as to what the requirements are. So if there are things that are unaddressed, so for example, the APS issue we just talked about, that's not something that's mentioned in the most recent QSO memo for nursing homes. That's something that we can address at a state level. We can be more specific. So it's kind of I'm not sure I want to call it a floor or ceiling scenario. It's definitely a starting point. So like, here's what the feds say. We can't come up with something that's in direct contradiction to what CMS has come out with, because that's going to put facilities in an untenable situation. And as a rule, whatever is the most strict, whether it's state or federal, is what facilities have to go with. So if we are more specific, that is going to be the requirement. Even if it's more specific than what the feds say, that's the requirement that facilities would have to go with. So it's both, it's our starting point and the minimum, but I don't want to say that it just depends on which one you're talking about. So like the county positivity rate, I don't think it would be a good idea for the state to come out and say, well, yeah, the feds say if it's, under 5%, you can go ahead with in-person indoor visitation, but we want to say it's got to be under 3%. I think that's going to set you up for some problems. But in terms of more specifics that we want to put out there, in terms of the conditions for what would permit in-person versus virtual, I think we can do that. If there's additional things, so Sarah Lineberg had mentioned, what if there's other outbreaks that are happening while this pandemic is going on? She mentioned influenza. Like, that's something that's not addressed in the memo. We can address that through this regulation. So it's kind of a floor, but it's also more of a starting point than anything else, I would say.
Okay, because the reason I'm asking is it does sort of, whether it's a floor or ceiling, does sort of color what parts of the conversation are, open for debate. So, for example, you talked about on page 3 of the guidance where the percentage positivity in the counties, and that piece is laid out. But then it also talks about other facilities other factors to monitor, such as rates of COVID-like illnesses or visits to the emergency room, or positivity rate of the adjoining county, et cetera, et cetera. So I guess what I'm asking is, I just want to make sure that if we're going to spend time discussing these matters, that we stay focused on areas where we can, where we don't get into conflict with some of those pieces, because otherwise we'll spend a lot of time talking about things that the feds have already decided.
Correct. So the paragraph that you're talking about, which starts on, I think, the top of page 4, if I'm recalling the memo correctly, where it says facilities may also monitor. So because that's in the CMS memo, that's a permissive statement. May is not shall. So if in discussing the conditions that we would like to place on visitation, whether it's in person or virtual, we as a panel should discuss, do we want to add in, like, as part of a facility's considerations, like, yeah, check your county positivity rate. Yes, you don't need no onset of COVID-19 in the last 14 days. Also, the state requires you to look at rates of COVID-19 like illnesses, et cetera. So that is something we can discuss because that's permissive in the CMS document. So that's the starting point, and we can be more specific and say, yes, you have to do that, and here's the numbers you should look at. Here's what's the yes, go, or no go for it based on, in the example you gave, the COVID-19 like illnesses.
Hi, Rebecca. This is Carla Thompson from Community Hospice Health in Richmond.
I'm sorry, who?
Carla Thompson from
Carla
Community
Thompson, thank you.
Health. Yes. Community Hospice Health in Richmond, and I want to speak on behalf of hospice and advocacy for dying people and their families, and address the first question there. Should the visitation requirements be the same for nursing homes, certified nursing facilities, and hospice facilities? And I would strongly say no, because the hospice facilities are dealing with a different subset of individuals who are all on hospice with a terminal diagnosis. And I really believe the compassionate care rule should still be there. In hospice, we often have to weigh the benefits and the burdens of what we do. And from a very humanitarian standpoint, the psychosocial and spiritual distress of isolating people when they are dying from their families, and the families' psychosocial distress and emotional distress because they cannot touch their loved one at the end of life. I think we have to weigh that in here to these rules. It is not always feasible to wheel a dying patient outside. It really isn't. So I would very strongly say hospice should be considered very different from the nursing home and the nursing facilities where individuals have a longer length of life.
All right. Thank you for that.
Becca, this is Matt Kestenbaum from Capital Caring Health. Carla, thank you for the comments. I wholeheartedly agree with you. I would like us also perhaps to consider any requirements that are put in place for hospice facilities. Clearly, we have patients in hospice that are dying in nursing facilities. And if there are exceptions for hospice patients within those facilities, might be an interesting question for us to consider as well. And I would certainly advocate for that.
Hi, this is Rebecca Morales, again from Beth Shalom. I have to go on the counterpart with that for the hospice patients in the long-term care facilities. I think we're opening up the risk factor because COVID in the elderly does mimic other comorbidities, the advancement of the death and dying process. You have varying illnesses that go along with that. With COVID, the failure to thrive, it mimics various things in our elderly population. I don't know that I can agree with that, so that's definitely something for all of us to consider.
Matt Kestenbaum again. Understood, Rebecca. I think that is certainly a valid consideration. I think this is where you work hand in hand with your hospice program to help tease apart what is part and parcel of the normal dying process and what could be COVID that would be difficult to distinguish. I think there's probably some place for middle ground here.
Sure, and we're currently doing the compassionate visits with the families, but they have to, have the proper PPE on. So I'm not sure
Perfect.
what other, what else there is. I wouldn't allow anybody to go in the room, if somebody's on isolation with hospice, to not have the proper PPE on, if that's what people are wanting to consider. Hopefully that's not. So, when Ms. Thompson was talking about, touching their loved one, I still think we all need to consider we need to continue the proper PPE and the proper infection control should something like that be in place.
Yeah, I don't think either of us were suggesting otherwise.
Very good. Very good.
Right. And I will note that the guidance from CMS, when it's talking about compassionate care, even when you have like a county positivity rate is high, where it says visitation should only occur in the compassionate care situations, even then it says, that compassionate care visitation still has to be done according to the core principles of COVID-19 infection prevention, which would include the PPE issue and other infection prevention methods and techniques that need to be implemented as part of that compassionate care visitation that gets to be permitted even when the positivity rate's high. Okay, so on the question, should visitation requirements be the same for nursing homes, certified nursing facilities, and hospice facilities? Ms. Thompson made the argument that no, they shouldn't be. Is there any? Does anyone else want to address that question as to whether they should be identical or that hospice facilities should be? I mean, they're going to be broken out anyway in terms of like how these requirements get put into the regulation. They have their own chapter for these sorts of things, but in terms of the actual substance of the requirements, did anyone else want to specifically speak to that question?
This is Veronica, and I see the merit, and I understand the advocacy put forth by the hospice representatives, and I'm also sensitive to just how dynamic the condition of a medically fragile patient can be. So I guess I go back to the framework Carter talked about. Will this regulatory framework and statutory framework allow us to? I don't want to box the facilities in, be they hospice or non-hospice, because if an individual patient, if that condition starts to change dynamically or just the different comorbidities with the medically fragile population, I would want the facility to be able to draw upon the compassionate care framework, and not I would not want us to box them in. Whether even if the patient hasn't been admitted to hospice, I would not want the facility to be boxed in where they cannot offer the compassionate care.
Can I ask a question? This is Joni Latimer. So I guess maybe it might be helpful if we just had kind of a restatement of the basic understanding here. It correct me if I'm wrong, but in reading, I hear what Veronica is saying, and I think that's a very valid concern. My sense from these most recent regs from CMS is that they are really emphasizing that there should be availability of in-person visitation with as long as those prohibitive situations, those prohibitive variables are not at play. So it seems to really emphasize person-centered needs and a wide berth for compassionate care visits being made available, not limited to hospice, end of life, and so forth. I think that seemed to have been overly restrictive, which was part of what led to CMS's reissuing of replacement guidance. Am I understanding that right? I don't know if Rebecca or Sarah or Kim might respond on that.
This is Rebecca. Rebecca Allen. Sorry, I realize we have two Rebeccas on the line.
Sorry.
It certainly seemed to be, from my personal reading of it, that CMS certainly emphasized in the opening to the memo itself that residents are, the social isolation issue, the whole COVID-19 situation being confusing and upsetting, that it's that CMS understands that these residents, there's value to them, both physical, emotional, and spiritual support through this visitation. So it seems to me that CMS, certainly recognizing the positive benefits of visitation, and by providing these more specific guidelines, is trying to enable facilities to be able to make the call to say, yes, you can come back into the facility, or in the case of outdoor visitation, yes, you can see your loved one in person, even if it is in a drive-by situation or some sort of outside setting. So that's how I personally read the memo, but if anyone has a counter argument to that, please let me know. But I think visitation is something that, I personally would value if I were in the nursing home, and that we should, in normal circumstances, we do want visitors to come in and see the residents, and there are programs that facilities put in place to have folks come in and visit with residents, particularly those who don't receive a lot of visits from their own family and friends. So I would think that we would want to, except when the following conditions say you shouldn't be doing it, that you should be allowing visitation.
Hi, this is Kim Beasley from OLC. Joni, I agree. I think the focus of the new CMS guidance is certainly encouraging more visitation, whether it be outdoor or inside. However, it is still heavily relying on outbreaks and county positivity rates and testing. And I guess the other part here is that guidance is specific to nursing homes. So when it comes to what we're discussing here, we have the opportunity, as far as hospice facilities are concerned, we kind of have the opportunity here, since there hasn't been any more recent guidance from CMS related to hospice facilities. We have the ability here to be a little bit more, gives us a little bit more leverage here on the state side with what we determine for hospice facilities.
That makes sense. Thank you.
This is Ron Cottrell from Hospice of the Piedmont. I may not have my arms fully around the issue, but I do want to segment a couple points here that regarding visitation, and particularly hospice workers going to area facilities. A challenge that we experience is that there's great inconsistency in terms of the accessibility of hospice workers going to area facilities. Some want that connectivity between the hospice team and the patients. Some very much restrict communication at all. Hospice providers have contracts with area facilities to deliver the Medicare required benefit, the hospice benefit. And we are experiencing great inconsistencies in terms of that accessibility in order to deliver hospice care. It's like a specialist coming into a hospital to deliver the care, and we're limited in some cases access to deliver the service to the patients that is required by the hospice benefit. So some consistency in terms of how we apply access for providers where there is a Medicare benefit is one issue, which may be a little bit distinct from the topic at hand of non-contracted visitors. But I think that first part needs to be addressed because we're running into significant variability amongst facilities where we're trying to deliver the hospice benefit. So that's one issue. The second issue then is non-providers accessing the facilities, and I think consistency certainly on compassionate care to assure that PPE and expectations set forth with regulation of what is required to be able to make a compassionate care visit should be clear and allow for access for family members to see a loved one at the end of life. That's been talked about. There could be variations in opinion on that, but I side with other hospice providers that that end-of-life experience and to deny access to a family member to say goodbye to their loved one is unconscionable to me. So there are some thoughts.
Hi, this is Marcy Tedderton. I'm with the Home Care and Hospice Association. I'd like to echo some of the things the previous speaker just said. And Kim, I do have one question for you. Yes, we have had issues fairly widespread across the state where hospices, even today, are continued to be denied to provide hospice services in nursing facilities that have where the patient has requested hospice services. We've seen a lot of barriers to staff going in and doing the work that they do to help people at end of life. I have talked with Virginia Healthcare Association about that. We have not really come to any great resolution on that. While we're empathetic to the challenges they face, certainly there has to be some sort of recognition of what hospice staff bring to the individuals at end of life, and we haven't seen that yet. There was a statement made earlier, Kim, I think it was you, you noted that there was a unique opportunity to do something for hospice facilities because they're not federally regulated on a state level. Have you had complaints from family members being denied access to their loved ones in hospice facilities?
No. What I meant was that in absence of any new or updated guidance from CMS on related to hospice facilities, we have an opportunity here to craft regulation addressing that, since we haven't had any updated guidance from CMS. I don't recall that we've had complaints from family members as far as being able to visit loved ones in hospice facilities. We've certainly fielded some issues with what you were just discussing as far as hospice staff not being allowed into, or maybe it was the gentleman before you, but hospice staff not being allowed in the nursing homes. We certainly have had that. That particular situation was addressed in some earlier CMS guidance, but I think in this most recent guidance, they're pretty clear on the subject of allowing hospice healthcare workers into facilities, as long as there's not, again, there's certain criteria, but I think as far as the facility is, under that 10% county positivity rate, I think it's pretty clear this time around about how what they expect as far as hospice being considered essential and allowed, in.
Tim, I thought the initial guidance was pretty clear to me, but obviously it wasn't to the nursing facilities. That continues to be an issue. And so I don't know that adding any particular state regulation is going to particularly fix that at this point. Nor do I know that we necessarily need to have any additional regulation around hospice facilities and what they allow or they don't or haven't allowed during this COVID-19 pandemic. I would like to get the gentleman that spoke previously as hospice is at Piedmont. They have a very robust hospice program, hospice facility there. I would like to hear from him what modifications they made to some of their policies and procedures, if any.
Yes, this is Ron Cottrell again. Anyone visiting, of course, is screened upon entry. Temperature screening questionnaires are completed. PPE is provided to all visitors so they can connect and stay with their loved ones. So both in our Center for Acute Hospice Care as well as our hospice house, those are the protocols that we deploy to assure safety for the visitor themselves, the patient, of course, and staff. Follow the CDC guidelines and assure that anyone entering the facility is screened appropriately and protected through PPE.
Rebecca, this is Carter Harrison. I can appreciate the issues that the hospice providers are raising, but I wanted to point out that we're supposed to be a regulatory advisory panel on the legislation that just passed related to, specifically to the visitation guidelines and less so to some of the other problems that folks are experiencing. While I certainly acknowledge they exist, I'm sure, and are a problem, we don't have a lot of time to focus on specifics that are contained in the bill. And I'd like to hope that we can, Marcy, your line's open. There you go. I'd like to hope that we can refocus on the specific item that you asked us to have comments about, which was the little I in number 28 and the same little I guess, for down in the hospice facilities section that's a little bit lower.
Yes, this is Rebecca Allen. Yes, thank you. So as I mentioned when Joni Latimer had brought it up in regards to APS access, by the variety of folks who may need access to residents is not the topic of conversation for today. It's more appropriate to discuss that under 2i, which was how folks can come into the facility, but also protect the health and safety of the residents and the workers who are at the facility. So those issues are for a later meeting. The specifics before us today are what conditions should permit in-person versus virtual visitation in the nursing facilities versus the hospice facilities. So with that in mind, CMS has given us several that the certified nursing facilities have to consider. We don't have anything from CMS, the hospice facilities, in terms of specific conditions they're supposed to be considering, because the last guidance we got from CMS was in March. So it sounded like from the hospice facility perspective that visitation is happening at hospice facilities throughout the pandemic, that while there have been restrictions in terms of the screening and the appropriate PPE that visitors have to don in order to visit their loved ones, that visitation is still occurring. Is that correct? Did I hear that correctly? That there's been no implementation or discussion of virtual visitation for hospice facilities?
That is correct. This is Ron.
I'm sorry, who is this? Okay. Go ahead.
Generally, that is correct. Virtual visits are encouraged as well, so it's not exclusive one way or another, but in-person visits as well as virtual are available.
Okay. With the conditions that CMS has put out there, so for example, the county positivity rate, are there instances for our hospice facilities where you would shut down in-person visitation and only let it be permitted via virtual visitation, phone, audio, visual, both, either, whichever?
We have not taken that action.
Okay.
And this is Carla Thompson on behalf of Community Hospice Health. The only time that would be enforced that they would have only virtual visits is if they were actively quarantined or screening positive. Then they, of course, would not be allowed to come in the facility, and we would provide virtual visits. Otherwise, we offer it and we encourage it, but we are not forcing them not to see their loved ones, and we provide the PPE.
So if a visitor has an active, you said the visitor's been screened out?
If the visitors are all screened, and if they have been recently exposed or screened as positive or have a fever, we're checking them at the door with their temperature. We're screening their likelihood to be exposed. If they are screening positive, then we would offer virtual visits only and would not allow them into the facility.
Okay. The reason I'm asking if there's any instance in which, because so your screening of your person, that's not necessarily a facility condition or a community condition. The reason I'm asking is because if there are no conditions listed in the hospice facility specific regulations that say, oh, if the following things occur, it has to be virtual, that means that the expectation is that, with the exception of your folks who are screening positive, that visitation is going to be in person all the time. That's what I'm trying to get at, is what instances in which, other than the person-specific screen, what facility conditions or community conditions would hospice facilities want to shut down in-person visitation and transition exclusively to virtual visitation?
Rebecca?
Yes.
Well, this is Marcy Tedderton with the Home Care and Hospice Association. This is how I would respond to you, and I'm a bit perplexed. So bear with me. We are required under federal guidelines to have emergency preparedness plans, and all of these things are being done through the emergency preparedness plans. So I realized we had a piece of legislation that was passed. Clearly that the intent of that was to focus on the nursing home, not the hospice facilities. The hospice facilities got kind of swept into it. Personally, I saw that as a no harm. But now I see that OLC, you guys are taking the position that you are required to put something very specific in regulation as a reaction to this particular piece of legislation. And that's what I find rather perplexing, why you would feel that when we already have the emergency preparedness plans, And those decision matrix are done based on what the science is telling us to do on any particular, it could be the flu, any particular issue. So why would the department want to do anything differently?
So, hang on, Marcy. I'm gonna mute your line back if you're done, just because there's a lot of
that's fine.
noise.
I'm sorry. Yes,
that's okay. It sounds like a lot of road noise in the background, so I'm gonna mute you so I can respond. Okay. So, the changes to the codes through these two bills, they are nursing home and hospice facility specific, so they require the exact same things in terms of what needs to be addressed in the regulation. So on the assumption that the governor's going to be signing these things, we have a mandate that we have to promulgate regulations that address all the things that were listed in the amendments to the various code sections. So we have an obligation that we have to fulfill. In terms of you mentioned the decision matrices that are in the emergency preparedness plans that hospice facilities have. I think having a conversation about what those, because it certainly sounds like those decision matrices they function as a type of condition level, or not condition level, a condition specific decision that's being made. So when you are using that matrix, you're looking at the listed conditions that are on there and saying, okay, yes, this condition is met. No, this one's not. As a result of these being met, these not being met, we do option A, option B, option C. So that's the conversation we're having, is what needs to go into that decision matrix for visitation in this COVID-19 pandemic that we find ourselves in, for both the nursing homes and the hospice facilities.
This is Veronica. Now that we have a point of reference, I'd like to take a stab at getting my perspective on these, and I guess anybody else can jump in as well. On question number one, I have heard several representatives of this panel who represent the hospice community talk about just the vital importance of them having access to their patients. They're running into problems, even though they don't have a regulatory ceiling necessarily. They're running into problems when their patients are in nursing facilities. So based upon what I'm hearing, I think it's important for the hospice patients who have been admitted to hospice but who are receiving care in a nursing facility. I think it's crucial for the hospice agencies to have unfettered access, the hospice staff members to have unfettered access. And if they feel like families need to have that, I think they've all spoken very passionately about how important it is for them, for their staff and their families to have access. So if we're going to speak to that requirement, if we're going to speak to what the statute requires us to speak to, I think that needs to be addressed, because we've heard of that issue. Number two, second bullet, what non-COVID-19 related conditions could impact whether to permit in-person visitation. Joni Latimer, our state long-term care ombudsman, has shared, I think, about 3 times on this call, and I appreciate the fact that she's persistent with us, that her understanding as the state long-term care ombudsman is that in-person visitation should be permitted unless there's some reason not to have it. So I think that to follow up on what Carter said, if we don't have some kind of regulatory or statutory ceiling telling us we can't do it, I think that we should embrace the position, that the reading that Joni has. You know, if our regulatory framework and statutory framework permit us to do that, I think that we should embrace that position. That's going to be in the best interest of these medically fragile patients. And then I'm not hearing anyone on this panel that represents long-term care facilities talking about situations. I think someone mentioned when the rates are up, or naturally, if a visitor has a symptom of any sort, if they can't pass the screening, they don't get in. Period. End of discussion. If they're going to put others at risk, they just don't get in. They have to utilize the virtual option. But to go back to what Joni said and what Carter said, if we don't have a prohibition, I think that our recommendation should be to permit in-person visitation with the appropriate enhanced sanitation, appropriate PPE, et cetera. I defer to the subject matter experts on what that looks like, but I think that in-person visitation is important with appropriate enhanced sanitization. Though the patients need, they need that contact. Number 3, what conditions in a facility and/or community should inform the decision to permit in-person outdoor visitation versus in-person indoor visitation? I believe that one of our speakers here has put forth very articulately that it's just not good to take some patients outside. Some patients are going to be in such a state that putting them in a chair and trying to wheel them out is going to have an inhumane tinge to it. Patients not going to be comfortable, et cetera. So that's what comes to mind. We screen the visitors. If the visitors prefer a virtual visit, if they feel like that's going to meet, the patient's emotional need and it's going to satisfy them, great. But for those people who are passionate about seeing that person and they pass the screening, I think the only, I think the deciding factor should be whether it's appropriate for that patient. I agree. Some patients, it's just not feasible. I'll refer back to a situation that I was involved with a few years ago, where there were visitation restrictions. Clearly not a pandemic situation, but there were some abuses with respect to guardianships, and the non-familial guardian was imposing some pretty severe visitation restrictions on family members. And you had a patient who was dying, and they would get the patient up, put the patient up in a wheelchair, and wheel them out into the lobby so that the receptionist could supervise the visit. And it was just really inhumane. So I think there have been people on this panel who've spoken to that. So that's my take on it, and I would encourage other panel members. I'm going to mute myself so that other panel members could weigh in. But I think that as a panel, if we could all embrace, where our ceiling is, and then make a recommendation that addresses the safety concerns with enhanced sanitization, PPE, a restriction on the fact that person can only, for infection control purposes, can only see the patient they're coming to see, but allow that visitation to the extent that we are able to do so from a regulatory perspective. Thank you.
Thank you, Ms. Williams. So going off Ms. Williams' comments, I will note that I have Judy Hackler, who's one of the attendees who represents VALA, the Virginia Assisted Living Association, has some comments as to the third bullet point, which I will circle back to. But to your point that, Ms. Williams, about visitation being that in-person visitation is the expectation, and that virtual is the alternative when specific conditions indicate, but in all other circumstances, it should be in-person visitation. I asked the rest of the group, is that a recommendation, not a recommendation necessarily, but is that a guiding principle we can all agree to, that the expectation is, absent any other conditions in the community, the facility, or a visitor being screened as having some sort of infectious disease, that the expectation is that facilities, hospice, and nursing home will be permitting in-person visitation?
This is Dana Parsons with Leading Age Virginia. I would agree with that.
Okay. With that being the expectation, oh yes, go ahead.
No, I was just going to say this is Vivian McDaniel from DNA, and I agree as well.
Okay. So that's the base that we will start from. Since that is the expectation, in-person visitation, what conditions, we're talking in-person only right now, what conditions would indicate that in-person visitation be outdoor instead of indoor as it is normally out, absent a pandemic? What conditions would direct the facility to say, yes, we're doing the in-person visitation, but we're not letting you physically into the facility. Instead, it's got to be an outdoor one. What conditions should we be looking at? Should a facility be looking at?
Hi, Rebecca. This is Carla.
Oh, whoa.
Sorry, Dana. Mine will be really short. And this is, I think, where hospice and nursing facilities need to divide, because it may be appropriate for nursing homes to have require the outdoor visits, but for hospice facilities, this could be detrimental to dying people to require the outdoor visits. So I think that's where we need to split.
Carla, this is Marcy Tedderton again. I appreciate that comment, and I think this is where, for anybody, it really depends on what's happening with the patient. Period. Whether they're in a nursing home or most certainly in a hospice facility, but when you start to get to this much granularity, I think is when you start creating issues for a number, because we don't know. You're asking us to sort of sign off on a policy that's going to be a blanket policy across the entire state about when it's appropriate for outside visitation to some extent, and that could be just sheerly based on a plant design of a nursing home. So I just think that brings up a lot of potential issues.
Okay. So for the hospices, it sounds like outdoor visitation is as a general matter a no-go, that it's an option that you always have again, we're envisioning a non-pandemic world. There's always the option, I guess, if your facility has the space, an outdoor space, that you could have visitation there. It's optional, but it sounds like from the hospice facility perspective, there are no conditions that would indicate in-person's not allowed, outdoors okay, wheel them out so they can see their family and friends. That there's never going to be a situation in which it has to be outdoor. It cannot be indoor.
This is Dana Parsons. I really think we have to defer to the providers on the phone to answer this question.
I really don't. This is Marcy. I don't see that. I agree with Carla's statement earlier. Ron, what are your feelings?
I think with appropriate screening, with safety, with PPE, access to a dying loved one should be permitted.
Hi, and this is Carla again, and I would echo that and say my concern is when we start putting regulatory rules around the requirements that we end up with people who don't meet all those requirements, but the compassion of the situation is such that we need to keep it a little looser and put it in the hands of the providers that are caring for the people to assure that we're implementing the proper safety and at best we can, but also weighing the benefits and the burdens in that given situation. And I worry about too much regulation over this, making it more difficult for us to help families and patients as they're dying.
Rebecca, this is Sarah Lineberger. I just want to echo the ability to put more detail in guidance and potentially less detail in regulation. And one thing that we may consider for the regulation is just requiring each facility to develop a plan to address the requirements that have been laid out in the bill, and essentially just saying in the regulation that a facility needs to develop a plan that works for their facility.
So to the point about just saying, oh, write a policy, the thing that we would, so in terms of the complaints and constituent responses or constituent mail that we've been receiving throughout this pandemic, a common theme that has popped up over and over again is, well, this facility does X, this other facility does Y, this third facility does something entirely different. So I understand the need for flexibility to be built into the regulation. I understand the need for providers to have the ability to exercise some discretion when it comes to visitation, but leaving it wide open, just for example, like if we just basically copy and pasted what's in the bill and dumped that into statute, that the level of inconsistency in what the minimum expectations are is going to be a point of contention, and I've no doubt will lead to complaints being filed that is just going to bring more people into the facilities. So the point of the regulation is to just set out what the minimum expectations are. I'm not saying we are creating this elaborate scaffolding into which your decision must fit at all times and there's no wiggle room. I'm just trying to figure out through this regulatory advisory panel what the minimum consistent expectations are for all hospice facilities. Again, they're in their own regulatory chapter, and all nursing homes and certified nursing facilities in their particular chapter. So we know, for example, on the nursing home side, at minimum, that there's certain conditions they have to consider when it comes to visitation, whether it's in person or not. The county positivity, the no onset of COVID-19 in the last 14, like those are specific things that CMS has set as the minimums that have to be considered. And so since conditions are things, conditions are part of the requirements that we need to be looking at, the reason I'm asking these questions of, yes, we all agree in-person visitation should be the expectation, should be the rule. We are now talking about what are the exceptions to that rule. So on the nursing home side, we know that some of the exceptions are going to be the county positivity rate. If it's this number, then you shut it down unless it's a compassionate care situation. On the hospice side, which is what I'm trying to tease out here at the moment, is are there any such similar sort of shut it down virtual only visitation conditions that they need to be considering? It sounds like the answer is no, and that's fine for the answer to be no, that 100% of the time visitation visitation will be in person. But the only time the visitation won't be in person is because there's something specific about a visitor and not something specific about the facility or specific about the community, which is true on the nursing home side. If there's something about the community, like their county positivity rate, they will have to shut it down so that they are in compliance with CMS guidelines.
Rebecca, this is Carter. Dana earlier asked to hear from some of the nursing home providers. I think we heard quite a bit from the hospice side, but I would be curious if the nursing home side has other thoughts about conditions that they would not permit in person and would instead do outdoor that are separate and apart from the CMS guidance.
Hi, it's Rebecca. I would indicate that, as Sarah discussed earlier, other infections that are in the nursing home, should there be the norovirus, I know that has happened in facilities before, or an undiagnosed stomach bug, something like that, or influenza, some type of outbreak. You don't want, visitors coming in, et cetera. That would be something that we would consider. And of course, just going by the CMS regulations that are already set out. But we've been doing the outdoor visitation already. And that seems to be going really well. We're getting ready to do the indoor. And like I said, we've already been doing the compassionate visits. So, since day one, and we've never kept anybody from seeing their loved one that could be end of life. That is one thing that we have held strong and dear to.
Will Blackwell here. We've also done the same thing. We've always allowed visitation for compassion visits, especially end of life. And, we leave it up to the family as far as their preference, if they like to visit in person in the room or outside in the garden, or we have a particular inside area that has visitation boxes already set up with plexiglass. So we leave it up to the family to decide where they want to go and what they want to do, and they reserve those spots. And that's what we do at Westminster Canterbury.
Rebecca, this is Sarah Lineberger. If I could just ask a related question of the providers and facilities on the line, something that we've considered and gotten a lot of questions about when we've written statewide guidance is the use of PPE or the availability of PPE and also face coverings. We've put in some of our guidance previously that providers coming in, including anybody mentioned on this call, like Adult Protective Services, the Ombudsman, inspectors, et cetera, should ideally provide their own PPE so that it's not taking away from the facility supply. But the expectation is that the facilities would be able to provide PPE to visitors because it would be less likely visitors would be able to bring their own PPE other than just some sort of face mask. But I don't know if that level of detail is something we would want to consider, but certainly PPE and any face mask covering, it would be something that we would want to consider for both outdoor visitation and in-person or indoor visitation, but definitely indoor visitation. So I'm just wondering if the facilities have any feedback on whether they would want anything in the regulation as to who provides PPE, and essentially where that supply is coming from. Obviously, we've had a lot of supply chain issues with all those supplies throughout the pandemic.
Hi, it's Rebecca. I don't think I would want a regulation to indicate where the PPE would come from. Definitely, we make sure that the families have the proper PPE. whenever they're entering the facility, but to have a regulation on who provides it, I'm not necessarily excited about that.
This is Veronica, and I also think that if people bring PPE from the outside in, you've got a potential infection control issue because you're introducing an unknown piece of PPE. You don't know where it's been, what's on it, et cetera.
Absolutely, Veronica, and we provide everybody with the new medical mask whenever they enter the building. I just don't want that regulation to stipulate.
I agree.
So in addition to yes, this is Rebecca, the other Rebecca. In addition to the point about other infectious diseases being something to be considered by a facility, whether they allow, to be considered by a nursing home, not just facility, a nursing home when allowing in-person versus virtual. Is there anything else? I know CMS listed in their memo other potential things that could be considered, which, included the positivity rate of an adjacent county. Is that something that should be a mandatory consideration for nursing homes or a discretionary one?
I feel like I'm taking up the whole time here. It's Rebecca again. I think for safety purposes, and I hate to say regulatory, but I would feel like that should be a regulatory situation. Just my personal opinion.
Yeah, this is Sarah Noble from Richmond and Henrico, and I would say, especially when you take into account the structure of our cities and counties, when you look at our cities, which are very small geographically, that, such as Richmond or Roanoke, you would have to take in surrounding county rates.
So in taking into account adjacent county positivity rates, or I guess if you're in Henrico County, you'd be looking at adjacent city county rates, you'd be looking at Richmond City. In that consideration, there's facilities will have to consider their own counties or cities positivity rate. That's going to be, they'll have to do that. In considering the adjacent county or cities positivity rates, is that going to be something we're going to want to see in there as you shall consider this when making the call as to whether to keep it in person, or is it going to be, in addition, you may consider this. You may factor this into your decision. It is not required that it be the case. Obviously, I wouldn't write it that way, but does that make sense? That it would be a discretionary thing as to whether they include that in their calculus in the regulation.
Yeah. So this is Joni Latimer. Just very briefly, I would just say that I think CMS probably pretty thoughtfully considered this, and I think wisely left it to discretion of facilities to take that in as an additional factor. I mean, we do already, as you said, have an absolute that you have to consider the immediate area, but I would think providers would want the flexibility to either utilize an adjacent county positivity rate or not, depending on their particular situation.
True, but as I had, in response to, I don't remember who asked the question now, about the CMS requirements, since it's discretionary in CMS, the State Board of Health does have the option to make it non-discretionary, that like you shall consider the adjacent county or city positivity rates, which is why I'm asking the question. I am asking for the expertise of the panel and not just wanting to rely on what CMS has done. Certainly their recommendations are a consideration whenever we do. I'm sorry, someone's got their mic on. Can they mute themselves? Thank you. Certainly that's a consideration when we are writing the regulations, but it's not the only consideration that we have.
Right, understood. But just to clarify, I'm just simply sort of emphasizing that, I think providers have sometimes felt like through this whole crisis that their hands have been tied to try to meet their residents' needs where things are, regulated that maybe should have been allowed discretion. And I think CMS has allowed it. I would think our providers would be the ones best able to discern, whether the adjacent county positivity should be considered by them or not. That's all I was trying to say. Thanks.
Mm-hmm.
Joni, I'm going to concur with you on that. And my thoughts on that would be we're assuming that the data is going to be available or the information is going to be available. I can certainly tell you in the early phases of COVID, it was not available. So, we're not just talking about COVID here. I'm assuming this is going to be much more impactful than just a single infectious disease.
So when it comes to what this regulation is addressing, it's only addressing visitation during the pandemic. The specific pandemic, I should say. It's the specific COVID-19 pandemic we find ourselves in. That's what the emergency regulation is addressing. So we do have, if we have the county positivity rate for, let's say, Henrico County, we certainly have the county positivity rates for Goochland County or Chesterfield County. So that data is available. And I think it would be poor practice for the board to put into regulation. We expect you to rely on this particular calculation or this particular metric when that metric is not available. That would not be something that we would ever consider putting into regulation. If the data source isn't available or isn't something that is updated with a certain regularity, then it wouldn't be something that the board would expect anyone to rely on. So that is something that we wouldn't be putting in there. But to your point, it is COVID-19 specific.
Thank you for that clarification. Then I guess my follow-up question is, are these going to be, these regulations will sunset at some point then, correct?
So, yeah, I think we all certainly pray that the pandemic ends eventually. So under emergency regulatory authority, the maximum amount of time that an emergency regulation can remain in effect is 24 months, and that's assuming you get a 6-month extension from the governor's office. So normal amount of time is 18 months, and if the governor gives the extension, then it can be extended for another 6 out to 24 months in total. Hopefully the pandemic won't last for another 24 months. Because the way the way the statute is worded or the way the bill is worded. Let me hop all the way back up. I have the hospice one on the screen, but it's the same for both. You'll see starting on the third to last line onto the second to last line, it says during a public health emergency related to COVID-19. So once the public health emergency ends, then the visitation regulation wouldn't be in effect anyway, because the regulation when written will specify that, like, when there's a public health emergency declared related to COVID-19, these are the following visitation requirements. And if that's no longer a declared state anymore, the visitation requirements wouldn't be in, well, I mean, they would still be written there. Obviously, they'd still be in the VAC, but they wouldn't have any effect on facilities at that point once the public health emergency declaration is ended. but they would ultimately sunset at 24 months. Yep. Maximum 24 months. Okay, so I've heard Ms. Latimer's argument as to keeping it discretionary in the state regulations. Is there anyone who would argue the counterpoint of it being a mandatory consideration? The adjacent county city positivity rates. Okay, hearing none. Another consideration that they had listed as a discretionary one at the CMS level was COVID-19-like illness visits to the ED. And I'm going to actually ask Sarah. Sarah Lineberger, are you still on the line? Sarah?
Yes.
Okay.
I'm here.
Oh,
I'm
okay.
Here.
Just making sure. What data? That's okay. What data do we have when it comes to COVID-19 like illness visits to the ED? Is that broken down at a county city level?
COVID like illness. What did you say? COVID like illness. What?
COVID-19 like illness visits to the emergency department are something that CMS lists as a discretionary consideration. Do we have that data in Virginia, and is it broken down by county, city, health planning region? Do we have it, and is it broken down? Like, how's it broken out?
We certainly haven't published that at a county or locality level. We do get data through our syndromic surveillance system regularly from emergency departments. So they are tracking COVID-like illness at the state and maybe regional levels to sort of inform the overall response, but that's certainly not something we've published at the locality level, nor do I think we would, I don't think that we would plan to do so unless specifically requested or needed.
And Sarah, this is Kristen Collins. I was just going to piggyback and confirm that on the website, under the COVID-19 Data Insights tab, we do have the COVID-like illness dashboard, but it is at the lowest levels at the health district level currently.
And so there are 35 health districts. Thanks, Kristen. This is Sarah again. There are 35 health districts. Sometimes a health district is a locality. For example, Richmond City is a district and a locality. But for most districts, that includes multiple counties and cities within the district. So if there was a request to publish that at a more granular level, that would have to be considered by agency leadership.
Okay, and the reason I was asking how exactly we have it broken out now is kind of to Marcy's point a few minutes ago about, well, if the data is not available, then are we going to be expecting them to make decisions based on that unavailable data? So regardless of whether it was a discretionary or mandatory consideration, I wanted to make sure the data was even available and at what level, because I certainly I wouldn't want to put in, even as a discretionary requirement, you should consider the rate of COVID-19 like illness visits to the ED by county, when that may not be necessary, that may not be available for certain counties and cities. So you're all the way out in Lee County, for example, they wouldn't be that information wouldn't be broken down, or at least isn't currently broken down, I should say, to that level. So facilities out that far wouldn't be able to even meet that discretionary requirement because they don't have that data available. That's why I was asking the question. Okay, so to the point about the COVID-like illness visits to the ED, which we now know, courtesy of our folks from Office of Epidemiology, that it is broken down by health district and not by locality. Is that something we would want to leave as discretionary or make it a required consideration when choosing to flip from in-person to virtual visitation? Anyone want to make the argument that it should be mandatory? Anyone want to make the argument for discretionary?
This is Carter Harrison. I think just given the fact that the data is only broken down by health district, I don't see how it can be anything other than non-mandatory.
All right, thank you. Okay. So those are the ones that were specifically called out as discretionary considerations from CMS. And as has been pointed out, Sarah Lineberger had mentioned the presence of other infectious diseases that could be occurring at the same time, either in the facility or community, that could impact the decision to move ahead with virtual visitation versus the in-person. Are there any other considerations for the nursing homes as to conditions, either required considerations or discretionary ones that nursing homes would want to look at? And by keep in mind it's facility level conditions or community level conditions. Conditions of specific visitors is a discussion for another day, because that gets into the requirements that we're placing on the visitors, separate discussion. So are there any other facility or community level factors that nursing homes want to have as part of the discussion and the considerations that they're making in making the call for virtual visitation versus in-person? To the third bullet that we have here, conditions in facility and or community that should inform the decision to permit outdoor versus indoor. I had mentioned earlier, after Ms. Williams had made her comments related to all three of these bullet points, but also to specifically the third one, that Judy Hackler had sent some information about that via the chat. She said that that these are conditions that should be considered. Weather conditions, especially as we're heading into our cooler months, the temperature changes for the community's doing outside visitation areas, the physical structures of facilities on whether there are private rooms available that can be used for visitation areas that would not increase exposure risk to other residents, such as those located near entrance doors that can be sufficiently sanitized after every visit. And this one's not facility or community specific, but she also mentions the health condition of the resident or patient as to whether they can be safely transported. So with those comments from Ms. Heckler, are in making the call for outdoor visitation, indoor versus outdoor, just generally, should that be a discretionary call by the facility, or should that be a, when the following things are true, it should be outdoor over indoor?
This is Veronica. I guess I go back to what Joni Latimer was saying. Well, restate your question, because I don't know if you're reading from the CMS guidelines. So I'm going to mute myself so you can restate it in the framework of what we're charged with doing.
So the State Board of Health is charged with coming up with regulations that address several things, including what conditions, including conditions in the facility and in the community, including those related to COVID-19, but not just that, that would permit in-person visitation or virtual visitation. Okay. CMS through their guidance, distinguishes between outdoor and indoor in-person visitation. So my question is, with the mandate that we expect to be coming our way and the existing CMS guidance about indoor versus outdoor visitation, should the call for it to be outdoor visitation be left to the discretion of the facility? Like the facility gets to decide, you know, when they open the doors to visitors, they get to make the call as to whether the visitation that day is going to be outdoor or the visitation is going to be indoor. So does the facility get to make that call, indoor versus outdoor? Or is it instead there's a series of conditions or factors they have to consider, and however they come out on the various factors, that will determine whether it gets to be indoor or outdoor that day?
This is Veronica. The one concern I have about the outdoor visitation is that depending upon the layout of the facility, my experience over the past few months during COVID with doing outdoor in-person visitation is that you become extremely limited. You know, it taxes the staff in terms of, you know, having that person positioned, having you where you're supposed to be, you know, just a number of factors to include weather. You know, we're coming up on weather changes. I kind of go back to the long-term care ombudsman position that we want to lean toward normalcy with the enhanced sanitization and you know, and proper PPE, and err toward default to indoor, unless, you know, I can't imagine what would require outdoor. I've just found it logistically cumbersome. My experience is that it was logistically cumbersome for the staff each time I had to do it. It was somewhat cumbersome for me and the patient having to communicate, you know, and I think once was through a screen. And the person was hearing impaired, so, you know, the staff had to be ingenious about how to make sure we could communicate effectively so I could carry out my statutory requirement as a guardian ad litem. So I would welcome, you know, candid discussion from the panel members who represent facilities on that, but that's just my perspective. I'll mute myself now.
Rebecca, this is Dana Parsons. I think that we really can't have a one-size-fits-all here. It really depends on what's in the best interest of the residents that day, and that decision should be left to the community. I would defer, again, to the providers on the call about that, but I think that they would want the flexibility, taking weather and so many things into consideration, to make that determination about what's best for that nursing home on that particular day.
Okay, thank you, Dave. Sorry, I was taking notes as you were speaking. Okay, so to sum up what I have heard, in-person visitation is the expectation for hospice facilities and nursing homes alike. On the nursing home side, that the call as to whether it should be an indoor versus outdoor situation is going to be discretionary for the facility based on several factors, to include weather conditions and, of course, the resident's condition, because some folks are, you know, bedridden, can't be rolling them outside. When it comes to the call on should it be in person or virtual, the mandatory conditions that are listed in CMS's memo are also, they would be mandatory at the state level as well. And it sounded like the other infectious diseases that could also be happening, which norovirus and influenza were the ones specifically called out by Ms. Lineberger, would also be required considerations. The discretionary considerations for a facility would include, in making the call between virtual and in person, the adjacent county or city's positivity rates and the rates of COVID-19-like illness visits to emergency departments at the health district level. Did I hear that all correctly? Is that correct for the nursing home side? It's not correct. Now's your time to say something. Okay, hearing nothing. On the hospice side, again, in person is the expectation at all times. And it sounded like from what we talked about for hospices that there were no circumstances, there were no conditions at the facility or community level, not the positivity rates, none of that, that would require the visitation to be switched from in-person to virtual. That it sounded like the only reasons why virtual visitation would be happening is because specific visitors have, there's something characteristic about a specific visitor that would prohibit them from being brought into the facility, such as a positive screening, or that's the one example that we have, but I'm sure we could think about this. Is that correct?
This is Ron Cottrell. That's correct.
Okay.
Hi, and Carla Thompson, and I echo that, yes.
Okay. All right.
Okay, this is Marcy Tedderton. That would be correct, Rebecca.
All right, thank you. So with all that being said, that does address, one second, that first bullet point, not first bullet point, I'm sorry, the first little I, both in our hospice facilities and in our nursing homes and certified nursing facilities. So that addresses that. Thank you very much for your contributions, all of you, on this point. For our next steps, I will flip back down there, but as I mentioned when we started this meeting, the plan is to work our way through all the little I's. So the next one is going to be the requirements with which in-person visitors will be required to comply to protect health and safety of the patients and staff of the nursing home or certified nursing facility, or if we're talking about the hospice folks, it's going to be the patients and staff of the hospice facility. So that will be the topic of our next meeting. Please come prepared to discuss access issues, since that has been brought up several times, both in terms of access from healthcare workers needing to come into the facility, such as our hospice workers, from our APS, CPS, all of those folks. So that access will be a subtopic within this one that we will be discussing. We'll also just be discussing the general minimum requirements that we're going to be placing on visitors, the PPE, the screening, et cetera. That's all going to be part of that topic under the two little I. If any member of this panel comes up with an additional subtopic that fits within two little I between now and the next meeting, please let me know so that I can make sure that that is included on the agenda. In terms of our next meeting, my understanding is that there is a long-term care task force meeting every other Thursday. Is that correct?
Yes.
Yeah.
Okay. So next Thursday is definitely out then, because the reason why so many of you can be here today is because it's not happening today. With that in mind, are you all comfortable waiting until the 22nd, Thursday, October 22nd, for the next RAP meeting, or would you like to have one sooner, but it not be scheduled on a Thursday morning in that case?
This is April. I think it's you know, what action items need to be completed by what date, and I think that's how we determine it, right? If you've got something that needs to be done sooner than later, then shifting to a different day of the week makes more sense than skipping a week in that case. Just my opinion.
Sure. So in terms of what's the timeline that we are looking at, so I did not quote this when I was putting the bill text on the screen. There is, excuse me, the third enactment clause of those two bills, it gives the timeline that the board has to work within. So emergency regulations have to be promulgated within 280 days of the the enactment of the bill. So because this is an emergency bill, as soon as it receives the governor's signature, it will go into effect that same day. So 280 days from whenever that day is. I don't obviously know what that specific day is yet. With all that being said, I do not want to take 280 days to promulgate regulations. There's certainly been a call and a desire from the regulated community to have this out here at the state level sooner rather than later. And with all that being said, I would like to have this packaged up and ready to send to the Office of the Commissioner by, I think we can get this done in, I'd say, 3 to 4 meetings in total, hopefully. So with that being said, if we had a meeting every week between now until the end of October, we could get this thing wrapped up by early November and sent downtown to the Commissioner's office by mid-November, because it does have to go through, just so everyone knows, I do have to run this past the Office of the Attorney General so they bless the text. So that is one thing that is sort of a hidden step that folks may not be aware of. But other than that, I'm fine having a meeting every week to get it done. Because like I said, I think it will take in total 3, maybe 4 at the outside meetings. And this is already the first one, so.
This is Ron Cottrell. I would encourage us to work with a sense of urgency to be able to get this in place. I know there is a lot of process, so weekly meetings I would be in favor of so we can address the issues at hand.
Rebecca?
Yes, who's this?
This is Vivian McDaniel. Are you going to do it after that meeting? Is that your plan, to do it after the biweekly meeting?
To do what after the biweekly? I'm sorry?
To schedule the next meeting if you're doing it every week, which is fine with me. But my question is, are you planning on doing that after the biweekly meeting, like 12 or a time after that meeting?
I'm sorry. You mean the long-term care task force? Sorry, I didn't recognize that you were referencing me to biweekly. No, that's okay. So I can do it anytime. If you all would prefer to roll straight from a long-term care task force meeting into a meeting of the RAP, we certainly can do that. I don't have a problem with that. Like I said, I'm fine meeting once a week to get this hammered out and get it sent up the various approval chains as soon as possible. Because, like I said, we have 280 days, but I personally do not want to take 280 days on this. I don't think it needs to take that long by any stretch of the imagination.
Now, I need to ask a question about those long-term care task force meetings. Are you referring to the ones that the Office of Epidemiology at the State Health Department is conducting?
Yes, those are the ones I'm referencing.
For the sake of proposing a straw man as a way to get our work completed, I thought today's meeting was very informative. Part of the meeting was introducing the topics and understand the work ahead of us. So I think our next meetings could be done, at a pace that is different than the one we had today with the information that we were able to share today. So I would hope that we could meet next Thursday, the Thursday after that, and see where we are to be able to finish our work.
This is Veronica. With respect to next Thursday, some of us have a wings meeting that conflicts with the task force meeting. So we would have to schedule it somewhat after the completion. I don't think you can roll right into it because I know the wings meeting is scheduled to last until noon. And the task meeting is scheduled to end at 11:30.
Yeah, I very much appreciate
that. And on that note, I was just wondering if we might consider a different day of the week next week if we'd like to keep on our weekly schedule.
Yeah, I agree with the weekly schedule. I just wanted to know the time conflict. Okay.
Right.
Sure. So I'm looking right now at all the various commitments. So
Actually, this coming Monday is a state holiday, but if that's the day that works best for the rest of the folks on the call who are not state employees, I'm happy to convene a meeting on Monday. It looks like, at least for me, that Tuesday looks pretty good. I know Thursday seems to be quite the party date with all the various meetings. Is Wednesday's a good day for me, but I don't know about the rest of the folks on this call.
Wednesday.
Yeah. Wednesday at 3:30. This is Dana. Could work for me.
Mm-hmm. Okay, Wednesday starting at 3:30?
Afternoon works. Yeah.
Same for me. Wednesday, 3 or anytime afternoon, I guess.
Okay, so I will send out an invitation for Wednesday at 3:30. What was I going to say? Hang on. Okay, I'll get that posted out on Town Hall, send out the invitation to everyone. It will be a virtual visit. Oh, Lord. Virtual meeting, just like the one that we're in now. If for some reason Wednesday does not work for you, as a reminder, you are welcome to send someone in your place to attend the meeting. All the meetings will be recorded. The recordings will be published out on the OLC website. I'm going to send a follow-up email after we get off this call that just sort of summarizes what the next steps are. And that will include the link to the specific web page that the meeting recordings will be posted to. It'll probably take a day to get the meeting recordings up because they tend to be rather large, and we have to send them downtown to our Office of Communications to be posted due to just the file size that they happen to be. In preparing for next Wednesday, 3:30 o'clock, in preparing for that meeting, is there any specific information or presentations, data, anything like that, that this RAP would like to see or to hear from specific groups on regarding that, the specific topic that we're going to be discussing, which is what requirements we are putting on visitors when it comes to protecting patient health and safety, and also the access issue, that too.
Rebecca, this is David DiBiase. Can you hear me?
This is who?
David DiBiase.
Yes, I can hear you, sir.
Okay. Before you get to that, I just wondered, I had a couple of comments today that I didn't seem to be able to fit in. Some of it was because I think I was muted. But when we were giving facilities discretion to decide things, I wonder where the conversation comes in about oversight. So, for instance, if a facility didn't allow in-person visits because they had insufficient staffing, who works with them to address that problem? Or if they lack PPE or inadequate testing, how are they held fully accountable for meeting their timelines and for remediating their failure to, be able to allow in-person meetings? So we gave a lot of discretion to facilities, but when do we talk about the oversight?
So I think that is a good point when it comes to the accountability. I know that the way that the bills are written, that visitation has to happen at least once every 10 days at a minimum. So with that,
but when they fail to meet that, what happens?
Right. So if they fail to meet that, there is a complaint process. If folks are if family, friends, whomever, residents are being denied the ability to visit with their loved ones, either virtually or in person, and I think that's one of the reasons why the virtual visitation is being discussed is as an option, so that they can meet that 10-day window. But if they don't meet the requirements, a complaint gets filed. It comes to the Office of Licensure and Certification, and we triage the complaint and do an inspection to see if the allegations are true. So I mean, there is complaint procedures both. I mean, since this will be a state requirement, there's going to be complaint procedures on the state side, but there's also obviously now through CMS federal requirements as well. So there's an enforcement mechanism on the federal side as well through the inspection process.
Well, ARP would urge that there's public reporting of this information so that residents and their families and the public can have a clear understanding of the status of visitation in any particular nursing home. And then we would urge that the state, require facilities to make, well, I'll leave it at that, but there should be more information about what is happening in a facility so that families and residents aren't kept in the dark while there's a complaint process going on behind the scenes.
Sure. So I know the statute mentions certain disclosures that facilities have to make as part of their visitation protocols. And when we get to that topic, I'm going to make a note to myself right now that the information to be included would be correct me if I'm hearing you wrong, but it would be the availability of visitation that day and what form it's taking, correct? That if for whatever reason a facility is having to switch from in-person, which as we said today is the expectation that that's going to happen, that if they have to, for whatever reason, switch to virtual, that will be somewhere available for residents and their family and friends to know that they don't have to drive out to the facility to be turned away at the door.
That is actually something else, but yes, that is something that we would want as well. But if they're not allowing in-person visitation for a number of days, and there are complaints about that, and it's because they're not a well-managed facility, they don't have the staff, they don't have the PPE, then that should be publicly reported so that residents and families have a sense of who's holding them accountable, what timeline are they on for remediation, and when will they get back up to, meeting the minimum requirements of the state.
Okay, I will say that when it comes to the mandatory requirement of at least visitation at least once every 10 days, that's just visitation writ large. That can be satisfied through virtual visitation, just to
right. But some facilities, because of insufficient staffing and insufficient technology and poor planning, won't even be able to allow virtual visitation because they're in chaos.
Okay. Yes, I will make sure that is I will make sure that is included as one of our discussion topics. I think since it's more focused on notice and remediation versus what visitor safety and health and safety requirements they'll have to meet, I don't think that would be one that would fit into the next meeting's topic, but I will make sure that is on our agenda for the third or fourth meeting of the RAP. Okay?
Okay. Thank you.
All right. Thank you. This is who?
This is Veronica Williams. I appreciate David's the points that David just raised. This is the meeting the meeting that we're in right now. This is the meeting where we addressed whether facilities would have the discretion to decide upon whether visitation was in-person inside versus in-person outside versus virtual, correct?
Yes.
Okay. And I like David, have some thoughts that I'd like to just share with the panel at large. One of the problems with having the discretion to opt to decide between whether today we're going to have in-person.
One second. 1 second, please. I for some reason the recording is paused. So 1 second. I want to make sure your comments get captured. Okay.
Follow your lead. You let me know when.
All right. Okay, the recording has resumed. I'm sorry about that.
Oh, that's okay. I appreciate the points that David just made, and they raised some things that I'd like to throw out and ask for some candidates, especially with respect to the facility representatives. When we talk about giving, I think that we said we were going to give facilities the discretion to decide on a given day whether they do in-person inside, in-person outside, virtual. Is that correct?
Yes, I believe that is correct.
Okay. And I agree, that is a huge amount of discretion. My experience with people filing complaints is that it could take months. And in a COVID context, I think that tends to be magnified. In any emergency context, I think all entities tend to be taxed even more heavily. And David mentioned the oversight point. I agree with Joni. My hope is that whenever we have an extremely vulnerable individual, it's the exception and not the rule. But a part of this is that compassion that we talked about for patients and family members. And when we start giving facilities the ability, the discretion on a given day to say no in-person today, separate and apart from the things that are mandated by federal regulation, but just outside of that, it's going to take more staff to orchestrate in-person outside visits. That, I think, is going to directly impact the ability to visit. It's going to create a reduction in visitation. That's been my experience, that it narrows that window when I visited with my statutorily required garden item visits. Can I ask the panel members who represent the long-term care facilities, not hospice, under what circumstances outside of the federal mandate would it be appropriate? Would you envision making a decision on a that could fluctuate from day to day to have in-person outside or virtual as opposed to in-person inside? Do we have any representatives who are here from long-term care facilities?
I'm sorry. I had two people that came in my office for something. Can you repeat that question?
Yes, ma'am, and I understand perfectly. I was wondering, from the individuals on our panel who represent long-term care facilities, we're talking about giving discretion for facilities to make decisions even on a daily basis as to whether they're going to have, and I know the Ombudsman's view is that it should be, the rule should be visitation unless there's some reason not to have it. It should be in-person, in-person visitation, and I would think preferably inside in-person visitation to prevent an added restriction on visitation just by virtue of the fact that it takes so much staff and logistics to get somebody outside for in-person. But what circumstance could our panel members who represent facilities, what circumstance could you envision that would warrant on a daily basis making a decision other than the federal mandate? Okay, the federal mandates are set. We don't have any option. We have to submit to authority. But with respect to the discretion, what could you envision as panel members who represent facilities that would warrant or necessitate a blanket rule on a given day that visits are going to be in person outside or virtual as opposed to in person inside?
honestly, aside from, what we've already discussed, I honestly wouldn't envision any.
Okay. So is there anybody else here that represents a facility that can share an instance where it would be appropriate or necessary, separate and apart from the federal mandate, to on a given day to say we're going to have in-person outside or virtual as opposed to in-person inside?
And like you said, and this is Rebecca again, and like you said, aside from what is already set in the regulatory guidelines that we currently follow.
Okay. So if I could make a recommendation, since we're still in this meeting, can I ask the panel members to make a decision about changing our decision so that instead of the facility's discretion, we say that it's going to be in person inside unless the federal authority mandates otherwise. And that way we don't have to deal with the oversight issues and the reporting issues that David raised. I think those would be necessary, but we don't have to deal with them if we take that discretion away.
So this
is David. You still have to deal with them if, it's oversight also of what if the regs are not followed? What if the CMS guidelines are not, or CDC guidelines are not followed? What's the oversight there?
I understand, but that's a narrower concern.
Okay.
That's a much narrower concern. Because going back to what, we're fortunate to have Joni on the call, our long-term care ombudsman, and she consistently tried to give us the context through which she views these, and I'm grateful that she framed it for us. We should defer to in-person inside with proper enhanced sanitization, proper PPE, unless there's some mandate for us to do otherwise. The federal statute has given us that mandate. I would ask our panel members consider taking away the discretion, for the individual facilities to deviate from that. Short of a panel member saying that there's a reason why that discretion is needed.
So this is Rebecca Allen. I will say that the CMS guidance that they've come out with says that the preference under that memo is that the in-person visitation be outdoor, weather conditions, health conditions, whatever the person permitting, because of let me read exactly how they have it written. 1 second. Outdoor visitation is preferred. It poses a lower risk of transmission due to increased space and air inflow. Therefore, all visits should be held outdoors whenever practicable. So I will say that CMS had, obviously in favor of visitation writ large, but they prefer the outdoor versus the indoor whenever practicable.
And that's for the nursing facilities, not the hospice.
Right, because it sounded like from the discussion we had that they weren't going to be moving patients due to their general condition if they're in a hospice facility.
And this is Joni. Just I realize it does state that there, and clearly they're underscoring, yes, do the safe thing when possible, but there are other sections of that, and I don't have it in front of me, I'm sorry, but that very, very much effectively say there should be allowance for in-person visitation as long as these specific bars are not these bars to in-person visitation are not part of the picture. So I think just logistically speaking, and Rebecca, I am more than sensitive to the amount of administrative burden and follow-up that is involved here for you. But I wonder if we might be we might call on you to just, you did that nice reiteration, sort of summation of what we had talked about and kind of how we had come out on these things. If we could get that maybe in writing as a follow-up here so that we can be thoughtful and maybe make some suggestions if we understood things differently than what you might understand or some of the others of our panel might understand.
Of course.
And,
thank you.
And I would ask the panel members to, because I'm hearing, I know that we don't have it right here, but I think that we have the ability to make a recommendation, and I would like for us to. I always want to honor the authority. If the authority mandates something, then that's it. Period. End of discussion. But if we have the ability here to safely implement while also honoring some of the impassioned pleas that I've heard on this call about compassion for the caregivers and compassion for the patients, to the extent that we can do that safely and we have the authority to do so, I would like to see us make a decision that it would be in person unless there's, some reason to do outreach. And I think we talked about, to be sure, hospice. I think a lot of nursing facility patients, it's just uncomfortable to get them up and to wheel them out to have that visit. And I think it also cuts down on the ability, on the ability to visit. I think I know the floor is every 10 days, but every 10 days is too long. For people who there are going to be some people who don't have visitors, but for those who do have visitors, I'd like to remove the stumbling block. And staffing issues, logistics orchestrating, in-person, outdoor, cuts down on the ability to visit. I'm going to mute myself.
All right. Okay, just to double check, I didn't hear any specific calls for our next meeting about specific data or information specific to that topic for the next meeting that the panel wanted to see. I wrote down Joni's note about.
Sorry,
yes?
it was hard for me to. This is Carter Harrison. It was hard for me to ping in things that I would like to see for the next meeting. Might be policies around testing for visitors that other states might have implemented. I know the CMS guidance talks about the fact that that's sort of optional or best practice, but not required. So I would be curious about how other states might have addressed that issue.
All right. I will make sure that is included as part of the presentation next time. Anyone else?
Well, this is Joni, and I, at the risk of, using too much airtime here, sorry. For one thing, I just wanted to underscore, I thought the comments that Veronica and David both made were extremely valuable. And I guess, we're sort of titrating, looking at what's going to be discussed at what point, at what meeting. So I haven't really ventured forward on the point that David made, but I think it's extremely important, and it shouldn't be a minor discussion. It's probably a pretty major issue to make sure that there's a process for dealing with, unreasonable bars to visitation when that occurs, hopefully rarely, and also that there be some consideration, some discussion and apparatus around transparency, so we really do have everybody on the same page and that consumers understand, families understand what's going on. I think we've seen a lot of concern with that through the whole pandemic period, where it's the lack of information too that creates a lot of issues. So just saying. Thank you.
All right. Well, if anyone has any other specific information that they would like to see included for our meeting next time about the health and safety requirements that are going to be placed on visitors. And again, we will be talking about access issues of specific types of folks who come to the facilities. So it's going to be your healthcare workers, your APS, CPS folks, et cetera. Please just let me know. You all should have my email address, but on the off chance that you do not, I'm going to flash it on the screen real quick here. Well, if I can get to it. There it is. So it's just my first name dot my last name at vdh.virginia.gov. Please be forewarned, my first name is spelled a little differently. So just make sure you're not sending it to rebecca.allen, that it won't go where you want it to go. So if anyone has anything else, please just let me know by email. That is the quickest and easiest way to get a hold of me outside of the WebEx meetings. Thank you all for your time. Like I said, I will be sending a follow-up email. It'll have the link to the recording. Once that has been posted, it'll also include a summation of sort of where we landed today on this particular topic, as Ms. Latimer requested. And I will see/hear from you all again this coming Wednesday at 3:30 p.m. Those invitations to that meeting will be going out here shortly. So thank you all for your time. If you need anything else, you know how to get a hold of me. And you all have a great Thursday. Have a good one now.
Thank you.
Thank you.
Rebecca.
Thank you.